Hey, um, so this is going to be a lecture for your module about pulmonary function testing. So you guys have had some exposure to pulmonary function testing in uh, CP Phys when we kind of talked about lung mechanics and volumes and things like that, and the mechanics of breathing. And then you got a little bit more of it when you got to respiratory disease, and you kind of had to understand how pulmonary function testing related to diseases like asthma, COPD, or your restrictive lung diseases. So, this chapter 20 in your Egan's book really focuses on everything to do with pulmonary function tests, what types of tests we perform when we say PFTs, um, kind of how different physiological alterations to the lungs can be seen on PFTs, and then just kind of the general principles between quality and infection control with PFT testing. Okay, so those are just a couple slides of objectives there. But now we can get into the nitty gritty of it. Um, Kind of the most important most important function of your lungs is going to be gas exchange. So when you breathe the air in, you're getting oxygen into the body and you're exhaling carbon dioxide out. So that exchange of gas is the function of our lungs. So there's going to be kind of four things that are going to affect how well that gas exchange happens. And that first one is like your diaphragm and your thoracic muscles. Those need to be able to expand and contract in order to produce that pressure gradient that's going to cause the air to flow into our lungs, right? So we learned in disease management about how neuromuscular disorders or disorders of the skeletal muscles can affect breathing and have a negative impact on breathing because it affects how well these muscles contract and produce that flow of gas. Your airways also, those air passages that the air travels through also must be unobstructed. Okay, so I've used the imagery before, like if I told you guys all to run down the hallway, that would be relatively easy to do. But then if I made it a challenge and like threw tables and chairs and a bunch of obstacles in the way, that would slow you all down and make it much more difficult for you to get to your destination. That is what happens in obstructive lung disease, is those air passages get narrowed or they get filled with secretions. They become inflamed, or you have that bronchial muscle constriction that's narrowing those airways, and that obstructs that flow of gas. There's also diseases of the lung tissue that affect that diffusion of gas through that AC membrane. So lung tissue disorders would be like your sarcoidosis, interstitial lung disease. ARDS is a lung diffusion defect disorder as well. So that relates to Fixlon, anything that is going to affect that thickness of the alveolar membrane is going to slow down that rate of diffusion. And emphysema also gets lumped into this category because emphysema affects the alveolar surface area. So that decreases the alveolar surface area, making that rate of diffusion slow down. All right, and then finally, the last thing that has to happen is you have to have that cardiovascular system and that perfusion of blood through the lungs and the ventilated alveoli, because gas exchange can't occur unless there's blood coming to those ventilated alveoli. All right. So pulmonary function tests are going to be very valuable in giving us information about things that are going to affect gas exchange. So there's kind of three categories we break PFTs down into. We have our dynamic flows of gases through the airways. So this is an example of spirometry. So spirometry, force vital capacity would be um, would be some of the measurements that we would take here. So this is your like FEV1, EV1, and your FVC are measured in this first category. Um, in your second category here, your lung volumes and capacities, this is where we're really looking for our total lung capacity and the breakdown of all of those volumes, including your residual volume. And then in the third category, this is looking for the ability of the lungs to diffuse gases. So this test that we perform is called a DLCO test. So it's your diffusion lung capacity. So that test looks at how well gas is absorbed into the blood from the lungs. Okay. So the purpose then of PFTs is to identify and quantify those changes in the pulmonary lung function. So that's just kind of saying it's there to detect that presence of pulmonary disease and then classify the type as either obstructive, restrictive, or mixed. We also use it to evaluate the need for therapeutic effectiveness. So this is, where we're doing, a series of PFTs to look at whether bronchodilators are effective therapies or if, pulmonary rehab is improving lung function for patients. We do them to perform epidemiologic surveillance for pulmonary disease. So this is where typically this is a screening that we do for occupational hazards. So if patients have work in certain areas that are more prevalent to lung disease, developing lung disease, they might get these screenings done yearly or every 6 months or something, just to make sure that we're staying on top of it, making sure that we're recognizing any underlying changes quickly. We also do it to assess a patient for postoperative pulmonary complications. So anybody that's having surgery, usually any cardiothoracic surgery, those patients always would get pulmonary function tests done beforehand. A lot of times bariatric surgery patients would also get pulmonary function testing done before they have their surgery, just to identify any risks for difficulty with weaning from the ventilator. And then finally, we do pulmonary function tests to determine pulmonary disability. So PFTs determine the degree of disability caused by lung disease. So if you have a patient that has asthma, or if they have COPD and it's bad enough, they might be able to get on disability because it affects their daily life function too much. So they would come into for pulmonary function testing for disability claims. There's only a few hospitals that do PFTs for disability claims. Sheboygan Memorial was one of them. We had special protocols that we had to follow if it was for disability testing versus just straight pulmonary function diagnostic testing. All right. So contraindications to PFTs. So typically we are not going to be doing PFTs on somebody who is not at their baseline. Okay. So a contraindication for PFTs would be you're not doing it on somebody that's acutely ill in the hospital, or even worse, if the patient's unstable in the hospital. So those patients would not be indicated to do a PFT. So remember that for your ClinSim exam, don't be recommending PFTs on hospitalized inpatients in acute COPD exacerbation. That is something that you could recommend with discharge planning for the patient to follow up with their primary and get a pulmonary function test done at baseline, but you are not going to recommend that in that acute phase. Okay. Some other contraindications are patients who are nauseous and vomiting. A lot of the maneuvers that patients have to do during pulmonary function testing, like the deep breath in and blast it out, that is not going to be probably very comfortable if the patient has an upset stomach, and the last thing we want to do is have the patient vomit during the procedure. If a patient's had recent cataract surgery, just because of that forceful blowing can interfere with the cataract surgery, we want to delay that and do it after the patient's had time to recover. If they're dementia or confused, they're not going to be able to achieve, like, probably not going to be able to achieve like optimal effort or repeatable results, which we're going to talk about a little bit later in the lecture. So these patients it would be contraindicated for them to have a PFT done. So in patients who are acutely ill or recently smoked a cigarette, we just have to know that test might not be very accurate. Okay, so smoking is, so we usually ask patients to withhold cigarette smoking on the day of testing. We usually ask patients if they've been ill in the last 2 to 6 weeks or hospitalized, and those patients then would be asked to reschedule their appointment. Okay. All right. So when you're breaking down interpretation of PFTs, you're usually looking for one of two categories. You're usually looking for obstructive disease processes that affect flow rate. So obstructive diseases, that's your flow rate is decreased. Restrictive diseases, your volume is decreased. Okay. So the primary abnormality in those obstructive diseases is an increase in airway resistance. So obstructive processes, your airway resistance increases, making it very difficult to navigate those narrow breathing tubes, and the air doesn't want to go through, doesn't want to go in or out. The primary problem with restrictive diseases is decreased compliance. So restrictive diseases affect the lung tissue, so how stretchy that balloon is, how much that balloon wants to stretch. Some diseases are both. Like a good example of diseases that are both would be cystic fibrosis. So cystic fibrosis is an example of both. Emphysema can also be an example of both. So you can have some restrictive and some obstructive components of emphysema as well sometimes, but mostly it's primarily we're talking about CF when it comes to restrictive and obstructive. Okay. All right. When you are looking at infection control, infection control is going to be a concern in PFTs because you have that risk of transmission through direct or indirect contact. So remember, direct contact is, my patient is sick and they, directly cough in my face and transmit the pathogens to me. Indirect contact is they cough all over my PFT equipment, it falls on some surface, some other patient touches that surface and indirectly becomes ill or infected with a pathogen. So indirect contact is probably the number one. Again, we learned this infection control in survey way back then, is that indirect contact is probably the number one way that things get transmitted in the hospital. Pathogens get transmitted in the hospital, through indirect contact. So important ways to protect ourselves is using standard precautions. So making sure that I wear gloves, washing my hand hygiene, cleaning off my instruments, and disinfecting them in between patients. So, wiping down the inside of my box in between patients. Somebody just breathed all over my stuff in there. I'm going to clean it off and wipe it down really good before I have the next patient coming into my lab. Um, there's also special recommendations for certain parts of the equipment that need to be like high level disinfected or sterilized in between patients. So manufacturers' recommendations need to be considered with that. Typically, the manufacturers I'm used to usually require you to do that, disassemble your equipment every month, do a high level disinfectant on it, and then reassemble it and perform like a quality control check on it. So typically that's monthly, but it is specific to the manufacturer. So you have to follow your manufacturer's recommendations. So um, when you are dealing with patients who have like tuberculosis, some special considerations for that would be that obviously the patient can't wear an N95 mask when they're performing this procedure, but using those HEPA rated filters should be used on everybody. And if you have somebody that is has some airborne precautions, you would make them the last patient of the day so that there would be enough air exchanges happening in that room before another patient would come. And then you would have to wear the N95 mask during the procedure to protect yourself. Any equipment that shows any visible soiling or condensation should be, discarded or disinfected before you're using it again. I think that's about it for that. Okay. All right. So we're talking about your pulmonary function equipment. There's two kind of measurements that we mostly make. So generally, the two measuring instruments are going to be the instruments that measure gas flow and the instruments that measure gas volume. So both of these instruments are also going to be measuring time and that it can compute those volumes and flow rates. Okay. So the term spirometer is sometimes used as like a generic term for all volume measuring and flow measuring devices. But spirometers are really specifically, volume measuring devices are really specifically called spirometers. So when your MBRC test talks about spirometers, you should think that measures volume. Okay. I think that this is probably a valuable thing to kind of have a flashcard about because I think that this might come up in a testing scenario and you would want to make sure that you are picking, that you understand what these terms mean. So spirometers measure volume. So they might use crazy things like water sealed bellows, dry rolling spirometers. So water sealed spirometers, bellows spirometers, dry rolling sealed spirometers, all of those things are the same thing. They measure volume. So if you know the term spirometer means volume, you know that the device, if they put any of those things in front of it, you know that that's a volume measuring device. Okay. So because it's measuring volume and time, you can derive flow rates from this, right? Flow measuring devices are instead commonly called pneumatachometers. Okay. So, so sometimes they'll call them Fleisch type pneumatachometers. But the pneumatachometers are the term that we use for devices that measure flow. Okay. Let's make sure here. Every device that you use in the PFT lab needs to be able to let me see how I want to say this. So every device in the PFT lab, whether it's spirometer, pneumotachometer, has a capacity, an accuracy, an error, resolution, precision, linearity, and output. And we're going to talk about what those terms mean. Okay. So don't get too wound up about this, but capacity of the instrument refers to the range or limits of how much it can measure. So if my capacity is I can um, measure volumes and flow rates in all adults, that would be an example of a capacity. So this instrument has the capacity to measure the total range of volumes for an adult patient and flow rates for an adult patient. That would be its capacity. Okay. Its accuracy is how well it measures a known reference value. So this the best example of this is with spirometry. When we're doing spirometry testing or force vital capacity testing, we use a device called like a 3-liter calibration syringe. Okay. So you use this calibration syringe and you perform like a series of measurements with the equipment to test to see if the accuracy of the equipment is within a certain percentage of the of that 3 liters. Okay. So typically we want that to be typically we want that to be within like 3% of each other. All the values to be measured within 3% of each other to be considered accurate. An error is a term we use for the difference between a reference value and a measured value. So that 3-liter syringe, if when I'm doing my measurements to test my equipment, it's my reference value is 3 liters, but I could measure, 2.97 liters. And then I have a 0.03 margin of error for that measurement. Okay. So accuracy and error are kind of opposing terms. The greater the accuracy of the equipment, that means more of your values are close to that 3 liters, the smaller the error. And there's kind of a mini clinic that's listed in your book on $3.99 that gives you this kind of information. Okay, to help you out with trying to understand that. All right. Okay, so resolution is the term we use for the smallest detectable measurement that we can make. Precision is a term that we use for kind of reliability or repeatability that we talk about in measuring the tests. So if you're in pulmonary function testing, we're always going to take multiple measurements. And if the values that are measured from any given test are within a certain standard deviation of each other, that indicates that the device is very precise. Okay. Linearity is the accuracy of the equipment over like the entire range of measurements. So not only the top range of that 3 liters, but testing it at like zero flow as well to see if, it's measuring, just like you would do when you're analyzing testing your FiO2 analyzers, you're going to be looking at 21% and you're going to look at 100%. So that's kind of that linearity, is I'm looking to make sure it's accurate at bottom number of the range and the top number of the range. Okay. Output is a term that we use for anything that's computed by the instrument. So, so that meaning that we measure some things directly, and then there's other things that we have to calculate based on those measurements. So just like, when we're measuring or calculating minute ventilation, we measure the tidal volume and we measure the respiratory rate and we calculate what the minute ventilation is. That's kind of an example of output. Okay. All right. So for quality control, we want to make sure that we're measuring things about accuracy at least daily. So typically we are going to, at a minimum, perform that 3-liter syringe accuracy test on our equipment every day before we start doing testing with patients. That's the minimum standard. It is best practice, though, in a lot of labs that are very high quality pulmonary function labs will do that 3-liter syringe calibration before every single patient. So if they have 5 patients scheduled that day, they will do that calibration before each of those patients does their PFT testing. So the nice thing about PFTs nowadays versus back in the ancient times when it really was a water seal and a bellows, and PFT techs would have to sit there with a pencil and a piece of paper and measure all this stuff out on the PFT report. Nowadays, we have computers that do all of that data acquisition and calculations for us, which makes our jobs a lot easier, but it also gives us a false sense of security that we don't have to understand things as much as we should to be performing good pulmonary function testing. I think that this is probably one of those scary things about respiratory therapy and pulmonary function tests is that there's a lot of RTs that have cross-trained into PFT labs, and their understanding of PFT stops at, I know the steps and the sequence of telling a patient how to do this, but I don't understand the values very much of what I'm getting from the patient. And if you don't understand the data that you're gathering from the patient, your likelihood of performing a good and accurate test goes down. So it's really important that if you guys ever get bit by the PFT bug and want to work in a PFT lab, which is a phenomenal career path, I loved my time in PFTs. It's more than just knowing how to coach a patient through a test. You really have to understand what you're seeing on the screen so that you can help troubleshoot and you can help correct the patient's efforts to get the best values and the best data collected to give to the doctor. So you really need to be trained and competent to administer these tests. This is why I think that even spirometry testing in doctors' offices should be done by RTs, not just nurses or MAs who know to tell the patient to blow really fast and hard, but don't know anything else about pulmonary mechanics. This is why I think it's always best for a highly trained RT to be doing these tests. Okay. So reference values and interpretations of the results. So the references that we use for PFT testing is based on a lot of population studies. So they've gathered a ton of data about this, and they have kind of created these normal values for PFT measurements. And these are based on height, age, gender, and race and ethnicity. Okay. It is also very important when you're doing pulmonary function testing or you're interpreting pulmonary function results that you look to see which references were used for that study. So there are, quite a few different reference ranges out there. So there's like Knudsen, cotton dust, Knudsen cotton dust, there's NHANES, I can't even remember all of them now. There's the new gold guidelines ones. There's a ton of different references out there. If you manage pulmonary function lab later on in life, or you work in a pulmonary function lab, you should be looking to update your references as new references come out. There is a lot of information out there. Like when I first started doing PFT testing, there was a big directive that said that African American patients had poorer, like less good lung function than Caucasian. They're Caucasian counterparts of the same age, gender, and height. So when you were doing pulmonary function testing, you were using references that really lowered the threshold for the African American patients. What we found now is that that actually is a really huge example of racial discrimination in healthcare and was never an accurate thing to do. So a lot of places have switched their references and updated them to reflect, our more modern understanding of lung function, and get rid of this, racial disparity. But, I would say that not every single lab understands their references the way they should. So you might walk into a lab at a small hospital, a small PFT lab that, is using an outdated reference. So that's something that's kind of important to understand. Typically when ATS, which is the American Thoracic Society, they are the governing body, they kind of make the rules for PFTs. So American Thoracic Society is the one who publishes guidelines for pulmonary function testing and kind of writes the rule book for how we should be doing things. They also come out with new recommendations and new guidelines fairly frequently, and it is important that if you work in pulmonary functions, or you supervise a pulmonary function lab, that you're up to date on the most recent guidelines. So they recommend reporting references for predicted value, the upper and lower limit of normal, and the Z-score. Okay. So the predicted value is simply the kind of average value derived from that patient population of healthy subjects. That upper and lower limit are mathematically derived to kind of create that range. And typically most healthy individuals are going to fall within this range. The Z-score is used to show deviations from that predicted value. So like a Z-score of like 1 would indicate the test was within 1 standard deviation of the predicted value. Okay, so we remember standard deviations from before. I know you guys really loved those, but that is just showing you, if I draw this out here for a second. Okay, so if this is my average right there, that would be my predicted value. So we'll give that my predicted value, PV. Okay, my range, let's say my range is from here to here. So this is my upper limit of normal, and this is my lower limit of normal. Okay. All right. So, and then my Z-score is the standard deviation, right, of that predicted value. So 1 standard deviation, let's say, is here, and 1 standard deviation is here. So +1, -1, and I could get data points all around here. So if I'm within all of these data points are within 1 standard deviation of the predicted value. So that would indicate like a normal test. All right. Okay. So when we are doing our measurements for pulmonary functions, they talk about sensitivity and specificity. Okay. So this is how easy it is for this PFT test to detect the disease or the absence of the disease. So if a sensitivity would be high, this would mean that the test is going to be abnormal whenever that disease is present. Okay. So, and specificity means the opposite. So specificity is high if the test is normal when the disease is absent. So some tests are really, really sensitive. So that means that healthy individuals are going to have um, uh, are not going to have like an abnormal test results. Um, and some tests are very specific, are very specific, meaning that the test is going to um, not result in, you know, abnormal results if the disease is present. Okay, so let me try to think about how I want to explain this differently. So a test is sensitive, again, whenever the disease is present, right? So if the test is going to be very, very sensitive. So let's say if a PFT test is going to be very sensitive in individuals with COPD. So that is saying that, oh man, sorry, that didn't work. It's making me angry. Sorry. Okay. So if my patient has COPD, okay, their spirometry test is going to be is highly sensitive, meaning that if they have COPD, it's going to show an abnormal result, which is true of PFTs and COPD. It's a very sensitive test for COPD because COPD patients are going to have abnormal results on their PFTs. Their FEV1, FVC is going to be less than 70% of predicted, right? So it is PFTs or forced vital capacity is a very sensitive test for COPD. Okay. It has a very high specificity for um, asthma, right? So, um, or in, it also can have a very high specificity, meaning that there's lots of different diseases that are going to cause this abnormal result. So it is not specific to COPD, but could be specific to asthma or other obstructive conditions. Hopefully that made sense. Um, okay. So validity, that what that means is whether or not it has the ability to accurately measure what it intends to measure. So we ensure our test validity by strictly following procedures and ensuring that the patient's making good effort and performing the maneuvers correctly, and that we've calibrated our equipment. That is how we establish that test validity. Okay. Reliability is a term we use when we talk about consistency. So reliability, in order to prove reliability, we need to produce consistent test results, okay, with minimal variability when repeated. Okay, so you have to perform each test more than once to get reliability because I have to show that it's the same on multiple tests. Okay. If I don't do either of these things, whether I don't establish validity or repeat the test and establish reliability, then these tests really are invalid and really aren't, and the doctor's really not able to make a correct diagnosis for the patient based on that. Okay. Because these tests are not foolproof. I've done PFTs long enough that I can fake obstruction on my PFTs if I want to. But a good PFT tech who was watching me and observing me perform the test would know that I was faking it and tell me to knock it off and make me repeat the test. That's why it's important to be highly trained and observant to what you're doing and aware of what you're doing and what your patient's doing when you're doing these PFTs. Okay. Let's look at this is actually the individual tests and measurements. So there's kind of three basic tests in pulmonary functions, and that's your spirometry, your lung volumes, and your diffusion capacity, which we've already talked about a little bit. Okay, so the first of these tests is your spirometry test. This is the most common test, pulmonary function test that we do with patients. So this is something that you might be asked to do in the hospital on a pre-op patient that is getting ready for heart surgery. So you need to do a screening spirometry before they go to surgery. So I guess that's the only example of an acute care setting that where a spirometry test would be effective. So it's not there to diagnose any, that patient is technically at their baseline, so it can be used to diagnose any underlying issues. The only other type acute setting you might do is if you want to use spirometry to check the effectiveness of bronchodilators or other medications that you're doing in the hospital. But again, it's not meant to be diagnostic when you're using it inpatient. So I would very much hesitant to recommend it as a choice on ClinSims tests. Okay. So actually, I think this might be a good spot to stop. I'm going to stop here with this video and then pick up talking about each of these tests in the next video, in the next lecture.